Welcome everybody to the BAUS Virtual 2020 conference and this symposium sponsored by Boston Scientific on post-prostatectomy survivorship. Are we doing it right? My name is Aaron Sahai. I'm a consultant urological surgeon with an interest in female functional and reconstructive urology at Guy's and St Thomas's hospitals, and I'm an honorary senior lecturer at King's College London. I'll be joined today by Majid Shabir, consultant urological surgeon, who's the lead for andrology and genitourethral reconstruction at Guy's and St Thomas's hospitals in London, and the chair of the BAUS section of andrology and genitourethral reconstruction. This is the hypothetical post-prostatectomy patient, and the interactions with the patient and the prostate surgeon or clinical team are not always in sync. We often hear that you're cancer-free now, so go on and live your life. Robotic operations have minimal side effects. Our job is to stop the cancer. I understand you have some incontinence, but I'll refer you for some physiotherapy. You don't really want to risk any more surgery. Regarding your erections, we can try you on some different pills. The patient, on the other hand, may be having some regrets possibly. I wish I'd never had this prostate surgery, especially if they've got significant functional complications. They may have been suffering for years. They may not be clear who they can communicate to or have easy routes of access back in to clinicians. If they're incontinent, the pads may be costing them a lot of money. Their personal relationships may be breaking down. But at the same time, they're also happy that their cancer is treated and sorted. And they feel lucky that they've seen a specialist. And sometimes they don't really want to interfere or burden the specialist, cancer specialist, with their functional issues. This is Mr. BH, typical case of a 62-year-old gentleman who's had robotic-assisted radical prostatectomy in 2012. He had a bilateral nerve spare operation, and he didn't have problems with erectile dysfunction or any bothersome LUTs in the preoperative period. Unfortunately, after this surgery, he's developed significant erectile dysfunction and post-prostatectomy incontinence, and he's significantly bothered by both these issues. At the 2-year stage, he's already been reviewed by a consultant, in fact, the consultant that did his operation, and 9 nurse clinic follow-ups. He has had some physiotherapy to help with his incontinence, and he's been put on tadalafil to help with the erections. In these 10 consultations, there's clear evidence and documentation of erectile dysfunction and urinary incontinence, but unfortunately, there's been no formal assessments, and there's been no referrals to the functional incontinence or andrology teams. In this particular case, 2.5 years, a urology fellow reviewed the patient who actually suggested more physiotherapy, but the patient had already undertaken quite a lot of physiotherapy at this point. He's needing 4 pads per day. At 3.5 years, he's referred for a specialist opinion to the incontinence functional team. The functional team arranged the appropriate tests. He has a 24-hour pad weight, which is 100 grams, urodynamics, and a cystoscopy. Ultimately, he's worked up, and 4.5 years after his operation, he's appropriately cancelled and ultimately entered into the master trial. He gets randomized to receive an artificial urinary sphincter. This has been a success. He's not completely dry, but he only needs a security pad, and he's delighted with the results of surgery. He wished he had had it sooner. His quality of life is much, much better. Golf was important to him, and he can play golf again with confidence. With regarding his erectile dysfunction, within a year he was recommended a vacuum pump, but unfortunately he was unable to obtain one, and he didn't really know who to ask or how to go about getting one. After 2.5 years, he'd been given multiple different PDE5 inhibitors and was told, really, these should work because you've had a bilateral nerve spare operation. Eventually, at 3.5 years, he's referred to the andrology team. He's given Cabajet L-Prostadil injections, and he's very happy with the outcome. Again, he feels that his life has been transformed and his quality of life is far better.
The incidence of prostate cancer has been increasing and has done so by 40% since the 1990s. Improved efficacy of diagnosis and treatments has led to increasing number of patients living with and beyond their cancer diagnosis. In fact, the number of survivors has tripled since the 1970s, with 78% of patients now surviving 10 years or more since their cancer diagnosis. And this increase in survivorship has led to an increase in optimizing the quality of life after treatment, and a big focus on this as well. When we look at the functional impact of surgery, there are two main domains that we think about: impairments to sexual function and impairments to urinary continence, and both of these can affect the quality of life of patients after their surgery. When we look at sexual dysfunction, mostly we think about erectile dysfunction, but there are actually a whole host of different things that can go wrong after a radical prostatectomy. An interesting study by the group at Memorial Sloan Kettering, where they looked at 336 patients who'd had radical prostatectomies and asked them to recall the information they were told about changes to their sexual function after surgery 3 months after their operation. Interestingly, about 2/3 of patients remember being told something about changes to their ejaculatory function. 1 in 10 men knew that there was going to be a change to the nature of their orgasm, but precious few knew about orgasmic pain or climacturia or changes to the penile shape or form. When we look at erectile dysfunction, the true rate is not really clearly defined in the literature because there is no agreed definition in any of the literature. A really interesting study by Tal et al., where they looked at a meta-analysis published over a decade ago at sexual function outcomes and erectile dysfunction after radical prostatectomy, and found that there were 22 different definitions in the literature at that time. And using those different definitions, be that return of spontaneous erections, a return to baseline function, or functional recovery using drugs or assisted treatments, the reported rates of erectile dysfunction were between 14 and 90%. If you ask patients what they probably consider to be more realistic, looking to a back to baseline level of function is probably more important. And if you were to use this stricter definition, only about 16% of men who had good preoperative erectile function can achieve that after the surgery. And that was nicely demonstrated in a study by Nelson in 2013. And if you looked at the age cutoff, there was only about 4% of men over the age of 60 and only about 1 in 4 men under the age of 60. So if we use the analogy of the airline industry, if you think about a flight which hasn't gone according to plan, and you ask different people for their opinion, you may get one view from the cockpit, a slightly different view from the cabin crew, and a very different view from the actual passengers in the plane. And the same is true when it comes to outcomes after surgery. We have to get the opinions of all. And a really interesting study which has been published this year, which is the Europroms data from the Europa UOMO group, where they looked at patients across Europe in 24 different countries and almost 3,000 patients, looking at what their outcomes were and quality of life 6 years after they'd had some treatment. And this is both after surgery and other forms of prostate cancer treatment. They used a series of validated questionnaires to check outcomes after their original interventions. And it was interesting to see that the impact on sexual function was by far and away the biggest problem after they had had their treatment. About 50% of men reported that sexual function was a moderate or big problem. About 1 in 3 only had actually tried a device or medication for treatment. And if you look at those bars, the green bit is the bit you need to focus on. A very small number of patients had a favorable outcome from treatments, probably much smaller than we'd seen from studies before. And importantly, this impairment in function had an impact on mental health as well, with about 45% of patients reporting some degree of anxiety or depression. Similar figures have been seen from studies in the UK, a very good large study, which was done by the Movember Group in association with Prostate Cancer UK, 35,000 men across the UK, 18 to 24 months after their prostate cancer diagnosis. And again, the same kind of numbers, 45% had a moderate or big problem with their sexual function after the operation. Only about 44% were offered any form of intervention and treatment, and only about 40% found that it was of any use. If you're looking at the same study and the outcomes from a continence point of view, 13% still had a moderate or big problem with incontinence 18 to 24 months after their surgery. If we look at the era of robotics, where we think things are going to be better, things may not always seem as much as you would expect. And this was a very nice study, again, by the group at Memorial and Sloan Kettering, where they looked at the regret of patients after they had had surgery, and they compared patients who'd undergone an open radical prostatectomy or a robotic approach. They found that patients who underwent a robotic approach expected a shorter time to erectile function recovery, 6 months versus 12 months. They had a higher likelihood of expecting to get back to their baseline erectile function. And they also thought there was going to be a low need for interventions like intracavernous injections. And it seems that the dawn of the robotic era has led to an increase in regret and an importance on the counseling of patients before their operation. Again, study from the same group looking at the progress and functional outcomes over the last decade, where they took probably the best index patients, 2,300 patients who underwent a radical prostatectomy with the most experienced of surgeons, and they looked at those who had just had a bilateral nerve spare with no need for any adjuvant or salvage treatments, and they looked at their erectile function 12 months and 24 months after their surgical treatment when they had good function before. What they found was that there was no real difference in the outcomes with erectile dysfunction from patients treated at the start of the last decade to the end of that decade. And more efforts were needed to improve patients' care after radical prostatectomy to improve our functional outcomes.
If we move now on to post-prostatectomy incontinence, the etiology is multifactorial. Continence is dependent on the detrusor muscle, the proximal intrinsic sphincter, the external rhabdosphincter, and the urethral suspensory complex, as depicted in this diagram here. Radical prostatectomy in some way removes several components of what's just been described. There's certainly an effect on the proximal internal sphincter, the rhabdosphincter, and the supporting structures. Innervation in the vasculature is also compromised, and in particular what's relevant is the pudendal nerve and its supply to the external sphincter, but also possible denervation of the detrusor muscle and the trigone. This can all lead to stress urinary incontinence, overactive bladder, detrusor underactivity, or loss of compliance, all which can contribute to post-prostatectomy incontinence. If you look at urodynamic results at a year, it's clear that the urodynamic stress incontinence is almost guaranteed at 88 to 100%. Detrusor overactivity is seen in a third, with detrusor underactivity also in similar numbers, around a third. But often there's combinations of the above diagnoses. Incontinence is dependent on many factors. Here are just a few examples. Operative technique clearly plays a role, and prostate volume, as in what I mean by that is the volume of the surgeon. Anatomy is important, whether there's been anterior and posterior reconstruction, whether the patient had pre-existing lower urinary tract symptoms or had a TURP, his age, bladder BMI, radiation status, and of interest, of recent interest, are some radiological features such as membranous urethral length, as assessed on MRI. When assessing continence, we're interested in the history, examination, avoiding diary, validated questionnaire assessment, and urodynamics. Severity is interesting because we can talk about pads in the number, but that's often a poor way of assessing severity. Perhaps what's more useful is 1 hour or 24-hour pad tests. Prevalence, again, is very variable depending on what we're asking and the definitions. It depends on timing. The prevalence of continence, or incontinence, I should say, is rather quite high in the early postoperative period in many cases, with a natural recovery over 12 to 18 months. It also depends on the definition, as highlighted on the previous slide. Based on urodynamics, stress incontinence is almost guaranteed at the 1 year point. But the outcome may be different if continence is assessed with a validated questionnaire. It's also important to understand this could be influenced on who's answering. Is it the patient or the surgeon? Ficara et al. Published a meta-analysis in European Urology in 2012, which suggested 65% had continence at 3 months, which went up to 88% at 6 months and 91% at 12 months. Another study suggested 68% are pad-free at 12 months, which begs another important question. Do all men who have incontinence need a pad? And if so, maybe using pads as a proxy is not ideal. I think in 2020, a consensus is emerging that the best assessment is about patient-related bother. This was a nice study by Tutolo et al. This was a 25-center study from Belgium with over 5,000 patients involved. Clinical, pathological, and follow-up data following on from robotic-assisted radical prostatectomy was inputted into an electronic registry for around 6 years. This was stored by the Belgian Cancer Registry. The main outcome of the study was to see whether continence was predictable, one of the outcomes, and in particular using the ICIQ-UI, the International Consultation on Incontinence Questionnaire UI, at 12 months. The higher the score, the greater the severity of incontinence. What the study found, essentially they looked at two models, whether incontinence could be predicted in the preoperative setting, and then post-surgery, how likely it was you would be incontinent at 12 months, and perhaps in the post-operative model, would this push you into having earlier surgical interventions? What was clear, what the risk factors was the EAU risk classification. If you were in the high group for biochemical recurrence, if you'd had radiotherapy, and if you'd had preoperative poor quality of life as assessed by the EORCT-QLQ-C30, and significant urinary incontinence in the preoperative state based on the PROM assessment of the ICIQ-UI. Another important factor was patient age. These were the relevant ones for the preoperative model. In the postoperative model, it was the preoperative ICIQ-UI, patient age, and the postoperative 3-month ICIQ-UI score and quality of life scores. They were able to develop nomograms, and this is useful for patient counseling, again, as mentioned in the preoperative prediction of incontinence, but also in the postoperative prediction, which was interesting if further surgery could be planned. In general, the issues with functional outcomes following radical prostatectomy is that there's no clear consensus definition of what the problem is, as highlighted by the previous slides. There's no true understanding of its prevalence, no clear understanding of what degree of impact different causative factors have in its development, and no clear understanding on how effective strategies are to prevent it. If we look here at this slide, it essentially is looking at the interventions of radical prostatectomy-derived erectile dysfunction and urinary incontinence in England. This far left column here represents the HES data for radical prostatectomy in 2019-2020, and around 8,600 procedures were performed. In the middle here, the NICE guidance would suggest that 13% have moderate or severe stress urinary incontinence at 6 years, and the NHS England Specialised Commissioning document suggested that the figure for end-stage erectile dysfunction would be around 10%. This would translate to around 1,100 stress incontinence and 868 patients with erectile dysfunction. Now, although it's not subsequent years, but if you look at the similar year for the number of artificial sphincters, male slings done to treat incontinence issues, and the number of penile prostheses done, the numbers around 370 for continence procedures and 370 for penile prosthesis, which would equate to around 33% of the total number and 43% for those with erectile dysfunction. Clearly, there's a big mismatch here, but actually, if you then factor in the all causes of stress incontinence and the all causes for erectile dysfunction, the numbers are actually far greater, which would then translate to only 16% getting surgical interventions for continence and only 5% for erectile dysfunction. There are a number now survivorship guidelines being developed around the world. We have the American Cancer Society, which has suggested the dissemination and implementation of guidelines into clinical practice will be a step forward to improving the delivery of prostate cancer survivorship care. Likewise, in the UK, NICE have suggested to offer people who have had radical treatment for prostate cancer access to specialist erectile dysfunction services. And likewise, that suggested a similar strategy for those with urinary incontinence. They've also suggested specialist opinions should be sought by both andrology and functional specialists with an interest in incontinence. This was an impressive document from Australia, where they used a very robust 4-round iterative Delphi process to develop consensus on survivorship. Ultimately, 26 survivorship elements were identified within 6 domains. The domains were the health promotion and advocacy, shared management, vigilance, personal agency, care coordination, and evidence-based survivorship interventions. These domains provided guidance for policymakers, clinicians, community, and consumers on what is essential for step change in prostate cancer survivorship outcomes. Interestingly, the overall ranking of priority actions for change came down to 3 factors: patient communication kits for health professionals, the My Journey kit from diagnosis for patients, essentially a booklet, and alternative delivery models to improve access. And you can see some of these concepts of what we've tried to develop at Guy's and St Thomas's.
NHS Improvement have produced this how-to guide in conjunction with the National Cancer Survivorship Initiative about how to develop pathways of care for those living with and beyond their cancer diagnosis, with their whole aim to be to improve the quality and effectiveness of services for such patients. And it's a very useful document to read. It's about 103 pages long, but it does have some very key take-home messages, and as shown here by the 7 steps. And we use this as a framework for how we redesigned our service, and it's got some great top tips about how you can achieve some of the goals that you're trying to do with redesign of your service, and some good framework on how to do so by setting out assessments that you do to start off with: patient surveys, interviews, process mapping, review of complaints for common themes, using proms or focus groups to try to see where you are, but then doing actions such as making patient information leaflets, personalized care plans, and patient seminars, and finally looking at effective outcomes such as patient experiences of the new pathways, looking at the attendances to your clinics afterwards, proms and quality of life questionnaires, as well as looking at the impacts of your treatment on function afterwards. And this is very much what we did as part of our GUIDES project, which we did in collaboration with Boston Scientific. And this was all about assessing our current patient pathway to begin with and seeing what the index patient was going through to see how we wanted to change things for the future. We defined what we thought would be the optimal and best unified pathway. We decided on what would be the best validated questionnaires to use both pre and post-op, and then decided on what specific disease factors and patient-specific factors that we wanted to collect to see what were affecting functional outcomes in the longer term. We then redesigned our entire service to be able to deliver effective unified pathways, and having those standardized pathways allowed a platform for us to be able to recruit into trials and do further research. And all of this was done in very close collaboration between our functional team, andrology team, prostate cancer team, and of course, the most important of all, our patients themselves. One of the first things we did was to do a quality improvement project looking back at our patients before the start of our new service, and we took 2017 as our index year. We looked at all patients attending for the preoperative prostate cancer seminar before their RAP, and in 2017 we had 295 patients attending, and we looked at what their index pathway was and looked at their functional assessments and follow-up in their first 12 months after their surgery. Now, rather disappointingly, only 2 out of 295 patients had any form of formal documented assessment of their erectile function, and likewise for formal assessments of continence. But I think this is probably reflective of what happens up and down the country in many other centres as well. When we looked at what happened post-operatively, most patients had some form of informal assessment about their erectile function or continence status, but there were no formal assessments done over that 1-year follow-up afterwards, and that was quite disappointing. Other things that we found as common themes, the quality of reporting of functional outcomes was very inconsistent, and there wasn't a standardized way of saying how function was after surgery. It was difficult to determine what treatments patients had been prescribed and whether or not they were actually compliant with those treatments and how regularly they were using them. And another theme that popped up was patients having difficulty getting hold of some of their treatments, especially vacuum pumps, as our index patient did at the start of this presentation. what we tried to do was to take a route of prehabilitation, so starting our interventions from the time of diagnosis and before starting our first treatment. And at that point, we were assessing their baseline functional level, assessing comorbid factors that we thought may influence their outcomes, but also took that opportunity with our preoperative seminars to prepare patients physically and psychologically for what changes were going to happen after the surgery, giving them realistic timelines and proposed management strategies for anything that we thought they were going to encounter, with the whole idea being to reduce the severity and incidence of future impairments and the associated distress that we know that they could develop from them. So looking specifically at the GUISE pathway, we started off by doing our preoperative baseline functional assessments with validated questionnaires before their surgery. Patients had a variety of different parameters that were measured, which were disease-specific and patient-specific, and that was preoperatively, intraoperatively, and postoperatively, with timed functional assessments done at 3 months, 6 months, 12 months, and 24 months. All patients were followed up in our dedicated post-prostatectomy functional review clinic, which was a collaboration between functional urologists, andrologists, and prostate cancer nurse specialists in the clinic together. And using the standardized pathway, we eliminated variability, so it didn't really matter who you saw, you were going to have the same treatment protocol irrespective. And the idea was, again, that we could use early intervention with evidence-based strategies to try to optimize their outcome. And hopefully we'll be able to come back and report the outcomes of those interventions in years to come. Now, no talk about new pathways would be complete in 2020 without talking about the impact of COVID. Certainly led to a decrease in the number of RART procedures. Initially, that has come back up to normal again, although the second wave will probably have something to say about that. The other thing it's done is totally stopped us from having face-to-face encounters with our patients for their follow-up, but we shifted to doing things in different ways. And we started off by doing things with telephone clinics, but we're also looking at new novel ways in which to deliver healthcare from a distance, but still give the same high standard of care. And one of the things that we've been doing is working with app developers, Nexus, to try to develop ways of getting our patients to do their completed validated questionnaires and still continue their patient journey with their prostate passports that we've developed from a distance, but using electronic means. And the same app also allows them to have social prescribing platforms where they can, interact with their physiotherapy treatment regimes or treatments for erectile dysfunction, as well as getting support after their cancer diagnosis and treatment as well. And this gives you an idea of some of the base screenshots from the app, where patients have their summary data about their surgery, the date of their prostatectomy, the nerve spare status, their current PSA, and the date of their test, and the date of their next test, and kind of graphs of their PSA progression over time, but also about their functional tabs. And we have one tab for continence where you're looking at their pad weights and pad usage, as well as ones for erectile dysfunction, looking at their validated questionnaire scores, erectile hardness, and compliance with treatments. And hopefully this will help us to deliver the clinic and its goals in a much more focused manner.
If we now go back to our hypothetical patient, we can hopefully see with the new collaborative approach amongst the subspecialties of functional urology, andrology, and the cancer team, perhaps a slightly different conversation happening between the patient and the clinician. Prostate surgery has side effects, but we can treat them. We'll take care of the side effects too. Quality of life is as important as being cancer-free. There are good options to treat your erectile dysfunction and your stress urinary incontinence, and we have pathways in place to help you. We'll get you to a specialist straight away. The patient now is hopefully feeling much more supported. My ED and stress incontinence were picked up quickly. I have specialists attending to my needs, and I know now where to go for guidance. I'm glad I've beaten cancer and I can get on with my life. I feel like I have a plan to take care of my erectile dysfunction and post-prostatectomy incontinence. If we go back to the actual case we presented at the start too, that patient now would have regular assessments, 3 months, 6 months, 1 year, and at 2 years by specialists in incontinence and erectile dysfunction in a designated post-prostatectomy clinic. They'd be getting bespoke management of erectile dysfunction and incontinence, and there would be timely movement through these pathways, which are all consultant-led. With regards to erectile dysfunction, he would have been given a vacuum pump on discharge. He would have had early PDE5 inhibitors on discharge and early escalation to alprostadil or Cabajet injections within 3 to 6 months. With regards to his urinary incontinence, he would have had physiotherapy even before his surgery and then afterwards for certain. And given his particular condition and our new pathway, it's very likely he would have got his artificial urinary sphincter at 18 months, i.e. 3 years sooner. We're very grateful for your attention. We're very grateful to BAUS and also to Boston Scientific for sponsoring the symposium.